Good evening, everyone, and welcome to the webinar on the theme Pioneering the ADC Era in Breast Cancer. It gives me great pleasure to invite our Program Director, Dr. Niti Raizada, Senior Director, Medical Oncology and Hemato-Oncology, Fortis Group of Hospitals, Bengaluru, to give the context setting. Over to you, ma'am.
Thanks so much, Himanshi. Firstly, sincerely thank Kavina and AstraZeneca for hosting this session today. Well, we all know that we are discussing an extremely important topic, which is the era of today. Well, Hertinu, of course, has emerged as the most powerful therapeutic tool in breast oncology and has made a very aggressive disease into a highly treatable disease. Well, anti-HER2 therapy started way back in the late 90s with Trastuzumab as the monoclonal antibody. And now we have shifted to ADCs, and every day we have a newer ADC to discuss and newer target to discuss. We have dual blockade strategies as well, which have improved efficacy and improved precision. So I'll quickly summarize where we are in terms of the poster boy of today, that is Trastuzumab Deruxtecan. Well, antibody drug conjugates are the current era biologic missiles. And well, this was the whole spectrum of all the trials, which led to approval of Trastuzumab Deruxtecan by the FDA in 2019. The Breast-01 trial, the Destiny Breast-01 trial was actually a phase 2 trial in patients who were multiply treated with anti-HER2 therapy, and where we found out initial breakthrough for Trastuzumab Deruxtecan. Then there was Destiny Breast-02 trial, which was basically for metastatic breast cancer in patients who had progressed on TDM1, which was a standard at that point in time. And this trial definitely showed almost doubling of ORR, and median progression-free survival also tripled. And that's when we realized that this is a drug which needs to be used in all the settings. DB03 was a 1:1 randomization when TDXT was compared with TDM1, which was a standard at that point in time, and established the superiority of TDXT versus TDM1. The Breast Destiny 04 trial was the first phase 3 trial which showed first ever concept proof that HER2 low can also be an area where TDXT can be used. Breast 05, Destiny Breast 05 is the trial we all have been discussing now. And this is the trial of use of TDXT in the adjuvant setting, post neoadjuvant with a residual disease compared to TDM1. We already have preliminary data, which is superior in terms of IDFS, and hazards are in the tune of 0.47, which seems to be significant. Destiny Breast 06, therefore, is a trial for HER2 low and also moving on to ultra low settings. We'll be discussing this as well today. Then Destiny Breast 09 is a trial in which first line setting TDXT along with pertuzumab has shown in patients who have not received any treatment, that is treatment naive metastatic breast cancer. To again, the interim analysis shows a median PFS of 41 months versus 27 months. So again, looks like a very reassuring trial other than the side effect, which is interstitial lung disease in all settings. And now moving on to the neoadjuvant setting, we have Destiny Breast 11 trial, which discusses use of TDXT in the neoadjuvant setting. Again, initial results definitely look more promising. And then Destiny Breast 12 trial, which is currently an ongoing trial for brain mets, patients who have active brain mets or patients who have stable brain mets for use of TDXT in as a monotherapy. So with this, let me hand over the stage to Dr. Vishwanath, who will be talking on the changing landscape of metastatic breast cancer scenario. Over to you, Dr. Vishwanath. Dr. Vishwanath is the lead oncologist and senior consultant in the Department of Medical Oncology at the Apollo Group of Hospitals in Bangalore.
Thank you, Dr. Niti, for that introduction. And thank you, AstraZeneca, for this opportunity. So let me share my slides. Yeah. So in the next 10 minutes, I will be with that great introduction by Dr. Niti. Let's start with this changing therapeutic landscape of metastatic breast cancer. We all know that there is a significant paradigm shift in the way we treat metastatic breast cancer. And Dr. Niti spoke about the poster boy, the TDXT. We'll come to that later. So breast cancer remains the most commonly diagnosed cancer globally. And if you see the incidence, 2.3 million new cases are diagnosed all over the world. And that this was in 2020. And close to 7 lakh breast cancer related deaths occurred globally in 2020. And a quarter of cancers in women are all due to breast cancer, and 32% increase in age standardized risk. It is estimated that from 2019 to 2035, the global age standardized risk will increase by 32%, reaching an incidence of 59.63 per 100,000. So there is a significant burden of breast cancer globally. So breast cancer is classified and staged to determine essential prognostic information and guide appropriate treatment. So we all know there are two types of breast cancer histologically, lobular and ductal, and receptor subtype determined by the expression of the HER2 gene, and also hormone receptors, which include estrogen receptors and progesterone receptors, and the histological grade. And staging is based on the anatomical extent of the cancer, basically the TNM staging. And the AGCC is the most commonly used staging system clinically. And in many cases, but not all, biomarkers may be used to select the most appropriate therapy for a patient based on the underlying drivers of the tumor. So we do know that in especially in triple negative and in HER2 positive breast cancer, any tumor size more than 2 centimeters or node positive, we go for neoadjuvant chemotherapy. And depending on whether it is triple negative, hormone receptor positive, or HER2 positive, the treatment changes. And we also have some biomarkers like the BRCA mutation and the PIK3, AKT, mTOR pathways. So many new things are there. And based on that, we customize treatment. So HER2 was one of the first identified biomarker in solid tumors. The development of HER2 over time and the growth of precision medicine for HER2-related disease is depicted in this chart. So if you go back to 1993, it was when the ERBB2 gene was identified. And in 1985, the HER2 cloning was done, and the product of the CERBB2 gene was identified. And then the HER2 overexpression was identified in 20 to 30% of breast cancers in 1987. And 1998, we saw that by adding Trastuzumab to paclitaxel in HER2 positive metastatic breast cancer, there was a significant benefit. And in 2000, first line Trastuzumab and paclitaxel for HER2 positive metastatic breast cancer was EMA approved. And then Lapatinib and Capecitabine came in for metastatic breast cancer, and that received FDA approval in 2007. And in 2008, the same thing received an EMA approval. And in 2012, we saw Pertuzumab coming in, and that received FDA approval. And then in 2013, TDM1 came in, and then there were oncogenic mutations which were identified in breast cancer in 2014. And then Pyrotinib plus Capecitabine in metastatic breast cancer, all this came in 2018. But in 2017, Neratinib got extended approval for extended treatment for adjuvant HER2 positive breast cancer. And in 2019, we saw that HER2 dual fish DNA probe cocktail test was used as the Trastuzumab companion diagnostic. And then recently, since 2019, we've seen this Trastuzumab Deruxtecan trials coming in, and they've received FDA approvals. And Neratinib plus Capecitabine for HER2 positive metastatic breast cancer in 2020. Tucatinib somewhere in between 2020 and 2021. And we have seen this. And now we know that Trastuzumab Deruxtecan is being used significantly in metastatic breast cancer. And like Dr. Niti mentioned, that so many trials are running for even neoadjuvant setting. And we may also see this being used in the early breast cancer setting. So there are four receptors in the HER2 receptor family. Her family of receptors include HER1, HER2, HER3, and HER4. Upon ligand binding, HER proteins undergo dimerization and activation of their intracellular domains. HER2 receptors are involved in proliferation and differentiation and play a central role in the pathogenesis of several cancers. HER2 has no known direct activating ligand and may be in a constitutively active state or dimerize with other HER proteins. So we know, we all know about this, and then the downstream pathway activation. So HER2 positive breast cancer is the second most common breast cancer. Breast cancer subtypes influence the prognosis and treatment options. Traditional major classifications by treatment, there are three types. We have discussed this. And now we also have this HER2 low and ultra low concept. And if you look at the HER2 positivity, it is mainly in 15 to 20% of breast cancers HER2 positive, which is mainly talking about the IHC 3 plus or FISH or 2 plus and FISH positive. So, and then we also have luminal B and HER2 enriched luminal A and the triple negative basal like subtype as well. So the HER2 positive treatment landscape has evolved and it incorporates anti-HER2 targeted treatments since 1998 when trastuzumab was added, paclitaxel was added to trastuzumab, and it was used in the first line setting as well as in the second line metastatic as a monotherapy. And then trastuzumab in combination with AC and paclitaxel in the HERA. We have these four adjuvant trials, the HERA trial, the BCIRG 006, NSAPP B31 and the NCCTG 9831. All these trials have shown that the 1 year of trastuzumab significantly showed reduction in the recurrence by almost 50% as compared to not giving trastuzumab. And lapatinib in combination with trastuzumab in 2007, mainly in heavily pretreated setting. In 2012, the Dr. Sandra Swain's very famous Cleopatra trial came in, where we since when we've been using this trastuzumab plus pertuzumab plus docetaxel as part of the Cleopatra trial. And we also have those two phase 2 trials, the Neosphere trial as well as the Typhina trial, which have shown the proof of concept for using pertuzumab, trastuzumab, docetaxel, and carboplatin in the neoadjuvant setting. And then the TDM1 as compared to lapatinib and capecitabine showed benefit in the second line metastatic. This was through the Emilia trial. And extended use of neratinib post trastuzumab adjuvant for 1 year. That was the extended trial. And then the pertuzumab in combination with trastuzumab and chemotherapy in the Affinity, the adjuvant trial came in 2017. And then the Catherine in 2020, which showed that TDM1 in those who do not have a pathological complete response showed benefit. And then with the various Destiny trials, since then we have the Destiny Breast 01 in third line and beyond in metastatic, and Destiny Breast 03 in second line metastatic, and then the tucatinib in combination with trastuzumab and capecitabine in the HER2 climb study in second line plus metastatic. So ADCs have three key structural elements. So it has got an antibody which helps with target binding, internalization, and the FC effector function. And then we have the linker, which helps in the payload release. And and then we have the payload, which basically the type of cytotoxicity and the inter and intracellular release. So let's talk about again the first line HER2 positive metastatic breast cancer. This was a publication in the New England Journal of Medicine in 1998, where Herceptin plus chemotherapy was better than chemotherapy, and there was a close to 3-month PFS advantage. And look at the hazard ratio, which was 0.51. And since then, we have seen so many trials. The Cleopatra trial, you can see that unprecedented PFS advantage of 18.7 months versus 12.4 months favoring the pertuzumab arm. The Emilia trial, where there was a PFS advantage of 3 months, where in favor of TDM1 as compared to lapatinib and capecitabine. The Destiny Breast 03 trial, again, look at the advantage in the PFS, significant benefit. And then the Nala trial, which showed neratinib plus capecitabine advantage as compared to, this was almost numerically the same. And then the HER2 climb, where tucatinib plus trastuzumab plus capecitabine showed some modest advantage in PFS and also some intracranial benefit. And then Teresa trial as well as the Destiny Breast 01 trial. So despite the anti-HER2 systemic therapies enhancing survival, 30 to 50% of patients with HER2 positive metastatic breast cancer will develop brain metastasis. And patients with HER2 positive breast cancer are at a higher propensity for developing intracranial metastasis, which significantly impacts the survival and quality of life. And depending on the type of breast cancer, if you see the HER2 positive, you can see that those patients have got increased brain metastasis and also the triple negative breast cancers also have increased brain metastasis as compared to the hormone receptor positive, HER2 negative. So fewer patients with HER2 positive metastatic breast cancer are treated as they progress on therapy. So use the best treatment first, maybe the key to further improving outcomes in the setting. And 1/3 of patients with HER2 positive metastatic breast cancer treated with first line do not receive second line therapy. Not sure if this may still hold good with so many new drugs coming in and with also Cleopatra giving so much of benefit. To further delay progression and extend survival by providing deep and durable responses, the most efficacious therapy should be used upfront. So TDM1 and TDXT are approved antibody drug conjugates in HER2 positive metastatic breast cancer with the same target HER2 but with different mechanisms of action. So you have the TDXT where the antibody for both TDM1 and TDXT is the Trastuzumab. But the payload is different. Here in TDM1, it is M-tansine, but in the payload for TDXT, it is Deruxtecan, which is a topoisomerase 1 inhibitor. So the drug to antibody ratio is 3.5:1 in TDM1, whereas it is 7:8:1 in the TDXT. And there is no tumor selective cleaver linker, but here in TDXT, you have tumor selective cleavable linker, which is called cathepsin. And there is no evidence of bystander anti-tumor effect in the TDM1, but there is evidence of bystander anti-tumor effect in the TDXT. So overall, there is no cleavable linkers release their payload through all degradation of the antibody, but cleavable linkers only need interaction with the lysosomal proteins to release their payload. So this is a major difference in the mechanism of action between these two drugs. And then we have the other drug, which is called datopotamab deruxtecan and the Satheesh deruxtecan, which have the same target TROP2 and mechanism of action, but are designed differently. So you have the Satheesh where the payload is topoisomerase 1 inhibitor, the SN38. The linker is plasma unstable cleavable linker, and 90% of the payload is released after 3 days. And the half-life is 16 hours, and the dose is 10 milligrams per kg body weight IV on day 1 and 8 of a 21-day cycle. And this is the Sacetuximab govitecan, and the datopotamab deruxtecan. The payload is again the topoisomerase 1 inhibitor, which is DXT. DXT is 10 times more potent than SN38, and the linker is plasma stable in contrast to Sacetuximab, where it was plasma unstable, and 5% of payload released after 21 days. But there we saw that 90% of the payload was released after 3 days. So, and the half-life is 5 days, which is much more as compared to SASI. And the dosage is 6 milligrams per kg body weight IV every 3 weeks. So just to summarize, I think we are seeing a major change in the treatment options for especially HER2 positive breast cancer, and we are having so many options now, and look forward to further talks. Thank you.
Thanks so much, Dr. Vishwanath. Actually, very nicely summarized. We'll go ahead with the next topic by Dr. Mansi Khanderia, who's a senior consultant medical oncologist at Sparsh Hospitals in Bangalore. Well, she'll be talking about understanding the HER2 spectrum, its biology, its heterogeneity, and clinical implications. We know that HER2 in a colorectal cancer is very different from HER2 in breast cancer. And of course, now we have HER2 in urothelial malignancy, HER2 in gastric cancer. So let's understand the intricacies. Over to you, Mansi.
Thank you, Niti ma'am. Thank you for this invite. And can you please share the slides from your end?
Sure, ma'am.
Yeah. Right. So I will go through the slides very quickly because this is mainly aimed at standardization of lab techniques, and I think we should talk to our pathologists about this more than just oncologists, because they will be deciding who is eligible to receive, ADCs or HER2-directed treatment more than us. And there has been a lot of change in the way we interpret the reports, as well as the prognostic and the therapeutic implication of these reports have changed over time. Is it going to take some more time, Himanshi? Okay. This is not the slide set. I'll see. Right. Yes. Right. First slide, please. Yeah. So as we know, I think Dr. Vishwanath has very nicely described how HER2 signaling is important in the biology of a disease, and how it kind of changes the entire outcome. So basically, HER2 family receptor is seen on the surface, but even without a ligand, it can kind of activate the downstream pathways. And there are three ways in which we these days pick up HER2. IHC, which we've been doing traditionally, which checks the HER2 protein overabundance on the surface, the receptor protein. And then there is FISH, which sees the abnormally high number of HER2 gene copies in the nucleus per se. And of course, there is NGS, where we see a mutation in the HER2 gene. So we have three methods in which we talk about HER2. Of course, the first two are much more commonly known and described, and how we've been interpreting it. Next slide, please. Next slide, please. Himanshi?
Just a second, ma'am.
I'm really sorry for this. What I'll do is I'll check it from my phone and continue speaking at least. So basically, we have two main ways in which we've been diagnosing so far, IHC and ISH. And it's pretty much standardized, at least when it came to breast cancer so far. So basically, IHC identifies the HER2 protein on the cell surface, and there are proper scoring guidelines which are separate for gastric and breast. And I think we still have to understand how in the other tumor sites we should be interpreting. So some labs are doing it as per the breast scoring, and some are doing it by gastric in other tumor sites. But largely, I think all of us follow, if it is a GI cancer, we try to follow the gastric kind, and otherwise we follow the breast type of scoring. And ISH is more or less standardized because it evaluates the total HER2 gene copies in the nucleus using a DNA probe, and the actual ratio is fixed. So basically, the number of HER2 fluorescent foci per nucleus normalized, or the number of CEP17 foci per nucleus, determine the amplification, and we use it as 17 as the single this ratio that we use. Next slide, please. So now, because of the Destiny trials, we have moved on from, we used to have HER2 negative, HER2 2 plus, and HER2 3 plus. We've moved on from that to ultra low, and now we are even to low, HER2 low, and now we are moving to HER2 ultra low as well. So basically, both of these studies told us that there is not just the 60 to 65% of patients that we see, we are missing out, because we are not kind of looking at 3 plus disease. So if we go to see in HR positive, HER2 negative breast cancer, almost 60 to 65% patients can be HER2 low. And now if you extend that to HER2 ultra low, then it's almost 90% of patients that will benefit from it. So next slide, please. Next slide. Yeah. So the changing paradigm of HER2 testing, like I said, is this, and I think the pathologist should be more aware of this. As we go through slides, it's quite repetitive, so I'll try to see if I can cover it in this slide itself. That the ones which suppose we in fact think that the positive should be seen properly and the negative we just look at one go and we discard them because you don't see that many tumor cells. But ideally, if it is IHC 3 plus, just 4 to 5 times magnification is enough, because you can see complete intense membrane staining of more than 10% of tumor cells. In 2 plus, if you don't see more than 10%, the pathologists are supposed to magnify it further to 10x and 20x, where you will be able to see clearly whether it is weak to moderate complete membrane staining is there or not there. And if you don't see even in that, then you are supposed to go up to actually 50x. So 20x to 40x is what is recommended. Only after they have magnified it to that level and seen that it is not really membrane staining is not completely on the membrane, then they are supposed to declare it as IHC 1 plus. So this has to be really impressed upon to our pathologists, that this is the method in which it is supposed to be done. And then again, if it is not 1 plus also, they should further be looking at the exact number of cells. So absolutely no staining is HER2 null. However, if there is 0 to 10% of cells which do have some incomplete or faint staining, then they will be classified as HER2 ultra low. So 5x to 50x is what they should be magnifying subsequently if they are not able to count the number of cells which are more than 10%. Next slide, please. Right. So basically, because of these two trials, like we just said, the whole spectrum has changed traditionally from two categories of HER2 negative to HER2 positive. Now we have HER2 low, HER2 negative, and HER2 positive. And very soon we are going to have HER2 low, HER2 null, HER2 ultra low, HER2 low, and HER2 positive. So we are going to go into 4 categories now from 2 categories. So it's very, very important that we are in sync with the evolving data and we keep our pathologists in sync with this data as well. Next slide, please. So majority of, we've all seen that we don't see that triple negative behave very typically like triple negative, but a lot of us would have seen HR positive patients which don't behave very typically like just HR positive. So almost majority of HR positive HER2 MBC patients express clinically meaningful levels of HER2. So we should see, if they don't behave in a very typical manner, at least get a repeat done. So guidelines recommend assessment of HER2 status and all, of course we know that. And those patients who also develop new metastasis. So any patient with a metastatic disease and a known breast cancer, we should be repeating the biopsy and we should be sending for all 3 of them, including HER2. And so 65% of these patients which we think are HER2 negative in HR positive setting are actually targetable, because they are either HER2 low or HER2 ultra low. So to identify those patients, it's very essential that we recheck the HER2 level after progression or when there is metastasis that newly develops as well. Next slide, please. So these are the 2 clinical important clinical practice recommendations, ESMO and ASCO. Next slide, please. This is to be followed again, like I said, for pathologists. But for us to understand, we should know that these are the criteria that are used, and we should emphasize on them in our reporting if they are not being reported. So ESMO consensus agreed that the term HER2 low may be used in clinical practice as cases determined by IHC 1 plus or 2 plus with ISH negative. They both will be classified as HER2 low. Next slide, please. So pathologists can make best practice efforts to distinguish IHC 1 plus results from zero by following the following practices. So what is the practice that should ideally be followed? I think we should circulate this particular slide to all our pathologists, because one is, of course, they should be staining it using the standardized guidelines, ASCO-CAP guidelines, and they should be examining HER2 IHC at high power, 40x, especially when discriminating from 0 to 1 plus of staining. And after that, they should get a second pathologist review when results are close to the 0 versus 1 plus interpretive threshold. So when there is a little bit of 0 to 1, even 1% confusion, we should be involving a second pathologist to review it. And they should be using controls with a range of protein expression to help ensure the assay has an appropriate limit of detection. And careful attention has to be given to pre-analytical conditions of breast cancer tissue samples for both primary. Basically, most of the errors that happen are in the pre-analytical conditions, where it is not fixed at the right time, or it is not fixed properly. So that is where most careful conditions have to be maintained. Next slide, please. Next slide, please. Again, this is like a revision of pathology and what we used to discuss for PDL1. So there are multiple assay kits that are available, and not just one type. Do we all even know or read? I'm not sure. We just look at the number of HER2, 0, 1 plus, 2 plus, 3 plus, and just decide what's happening. But basically, there are multiple assays that are available, and these assays should be used because these are typically optimized for HER2 positive breast cancer. And we should not really be looking at lab developed tests. We should be looking at standardized assays. So there is a Bond Oracle assay which uses a mouse antibody. There is a HERCEP test. I think a lot of us would have seen HERCEP test, which uses a rabbit antibody. It's the DACO assay. Then there is Insight HER2-Neu, which uses again a mouse antibody, and it is called Biogenex. It's from Biogenex. And then we have a Roche pathway test which is used. So this again uses a rabbit one. So I think most of us either see DACO or Roche, but these are the 4 ones which are FDA approved assay, and these should be preferentially used. Next slide, please. So this is again, like I said, it's a pathology revision. So this is how these different assays look. So 3 plus is circumferential membrane staining, that is complete, intense, and in more than 10% of tumor cells. Only then you call it as 3 plus. And they look quite similar in all 3 if you go to see. So it's very evident, very objectively visible in these assays. Next slide, please. Again, the same assays, when they see, they are quite similar. So weak to moderate complete membrane staining observed in more than 10% tumor cells is called as score 2 plus. And for these patients, we must order reflexish. I think we all have that reflex that we order it. So next slide, please. And the last one is incomplete membrane staining, that is faint or barely perceptible in more than. So this is the score 1 plus, which we call it as HER2 low. Next slide, please. And then if there is absolutely no staining, then we, or in less than 10%, we call it score 0. This is where we need more attention, because a lot of score 0 can be score 1 if not reported correctly, if not magnified up to 40x, like I told earlier. And if a second pathologist's opinion is not taken, a lot of patients who had score 0 became score 1 after taking a second opinion. So this is the most crucial zone where there is inter-observer variation. Next slide, please. So EQA scores are better with approved IVDs than LDTs, like I was telling. So there have been studies where Nordic QC and in UK, where they compared the lab developed tests with these approved assays, and obviously the rate of false negatives and false positives were much higher with the lab developed tests instead of these assays. So Ventana pathway, DACO, and Lisha was compared in the UK one. and Ventana had the highest percentage of pass rates in the UK study. Next slide, please. So like I said, differences in staining patterns and intensity is very subtle in IHC 0 to IHC 1 plus. Again, they're just re-emphasizing 3 plus can be identified at 2.5 by 5x, 2 plus at 10x to 20x, but for 1 plus, it should always be at 40x that the pathologist gives us the report. Next slide, please. So reiterating that HER2 ultra low is the most challenging subtype for pathologists because it has very faint staining. You need a higher magnification. The time needed is much more. There are individual differences in color perception because the staining is very, very faint. And of course, there could be confusion with potential cytoplasmic and non-specific staining patterns. So this is where we should keep checking and ask our pathologist to check again when they give a 0 to make sure that it's not 1 plus. Next slide, please. Next slide, please. So we all know that there is a proper pattern in which reports should be given, and I think most standardized labs do that. However, I do see even in my hospital between pathologists there is a lot of variation in the format that they use. So there are templates available which should be easily reproducible, and it is allowed to share these templates. So we can encourage our pathologists to use the CAP developed template, which should show a proper reporting pattern where there is consistency of data elements, improved completeness, and there is ease of understanding for pathologists as well as oncologists. Next slide, please. So this is the order in which things should be mentioned in a HER2 report, where first thing is you specify the HER2 assay used, then you report the score, which could be 0, 0 plus, 1 plus, 2 plus, or 3 plus. Then if completed, then report. If a fish was advised, then we mention the fish report, and then we make a complete report. And you also need to include the estimated percentage of tumor cells that were stained as well as the staining intensity, and then the final interpretation. So it has to be a very methodical and systematic reporting, and it should be standard between patients. Next slide, please. So there is also a footnote which can be mentioned as per the ASCO guidelines. That is here, I can read it out. Patients with breast cancers that are HER2 IHC 3 plus or 1 2 plus ish amplified may be eligible for several therapies that disrupt HER2 signaling pathways. And then they also mention this. So this footnote can be standard in all patients. Next slide, please. Again, this says the same thing, but it mentions about the ultra low. So CAP reporting template update refers to ultra low as IHC 0 plus, and it does include, that does recommend an inclusion of a footnote where it is optional to mention this, that HER2 low as per Destiny Breast 4 and 6 trials was considered as IHC score 1 plus or 2 plus, that is ish negative, and HER2 ultra low was 0. So this can be mentioned. It will give more clarity, not just to us, also to our patients, because these days our patients read these things, they put it on AI, they kind of interpret it with the help of these reports. So mentioning it will make our jobs easier because they will anyway be uploading this to AI, and then it can guide them towards the Destiny trials as well. Next slide, please. Next slide. So I think we all know that HER2 is a very dynamic expression. It changes with treatment and over time. It is very, very important that we keep testing HER2 every time there is a progression. There were some studies which showed that 9% of cases switched from HER2 0 to HER2 low, and about 15% of cases switched from HER2 low to HER2 0. In the primary versus the residual breast cancer. I think a lot of us in some other webinars have shared such cases where we've seen that a patient who was HER2 negative suddenly had brain mets, and then we saw that it was actually HER2 low or HER2 positive. So we should keep checking for this. Again, there is also another study in which patients with matched primary and recurrence samples show that 15% of patients switch from HER2 0 to HER2 low, and 14% switch from HER2 low to HER2 0. So retesting HER2 expression in the metastatic setting is key for expanding not just treatment opportunities, but even longer lives in these patients, longer survivals in these patients. Next slide, please. So multiple factors are responsible for us to, why we should be retesting it. One is, of course, every time there is a recurrence, we should be doing it. Or when the receptor status of the primary tumor is unknown and the patient presents with mets, we should be doing it. If the primary tumor is heterogeneous itself, this could really help. If metastatic evolution is unusual compared with tumor characteristics, again we should be doing it. So basically it includes all kinds of patients that we see on progression. So every single patient should do it, and a lot of places would not do it because of the TAT. But if the infrastructure can support safe and timely biopsies with short TATs, we should be doing it. So I think it's 3 days to 5 days in our setting, and we should definitely be checking for HER2 at every progression. Next slide, please. So even as per the trial and the subset analysis in DB6, efficacy of TDXD and HER2 prevalence is similar irrespective of the tumor collection or of the sample collection. So whether you take the biopsy from the primary site or you take it from metastatic site, if you do just a biopsy, or it is the entire surgical sample, or an entire node that has been excised, the efficacy of the drug has been same. So that is reassuring. Next slide, please. So again, just they are talking about the same thing, but this is results from some study where central scoring was done. And of all the samples scored as HER2 low locally, 94% met Destiny Breast 06 inclusion criteria. So overall percentage agreement was 77% for HER2 low. Next slide, please. So there was this paper in JCO which showed that prevalence of HER2 low, ultra low in IHC 0 status. So of the IHC 0 HER2 status reported within 60 days, 60% were determined as HER2 low when rescored. So 60% ultra low. So 60% can get another chance at a new treatment. Which is a very, very important, number of patients that would miss out on ADCs. Next slide, please. Like I said initially, the pre-analytical factors are extremely important. The sample collection, sample transport, preparation, fixing, all of that has the major impact on how HER2 is reported. Compared to the analytical and post-analytical, the pre-analytical cycle is where we should also be focusing on, so that the fixing and the reporting is correct. Next slide, please. The same thing that I mentioned. So type of fixation, time of fixation, method to tissue processing, time to slicing and fixation, all of these are really going to have a huge impact. Compared, of course, we need more competence, we need good assays, we need good reagents, and of course, we need good pathologists to interpret our reports. Next slide, please. So standardization of practices, quality assurance programs, automation have potential to be of significant impact. Next slide, please. So again, this states the same thing. Basically, pre-analytical phase is where maximum errors happen. 60 to 65% errors happen in this phase. Next slide, please. Right. So there is in that phase the importance of ensuring optimal cold ischemia time. So cold ischemia times and fixation methods do affect, and 0.5 hours, so half an hour of delay versus 3 hours delay versus 24 hours delay versus 48 hours delay, you can see how different the cells look. So fixation time in 10% of NBF should be between 6 to 72 hours, and sections should be 5 to 10 thick and cut within 6 weeks. This is very important, that they should be cut within 6 weeks of HER2 staining. Cold ischemia time should be as short as possible, ideally within 1 hour. So ideally within 1 hour, the tissue has to be cold ischemic. Next slide, please. Again, impact of storage of sections. So a freshly cut section definitely has much more validity than old, though we use older blocks, but ideally we should not be using sections which are more than 6 weeks old, which should be kept in mind, so that in case we want to recheck, we rebiopsy it if a patient comes to us after getting a biopsy done elsewhere and we want to rebiopsy. If it is after 6 weeks, we should rebiopsy and not just use the blocks for interpretation, especially when patients from outstation or international patients come. I think this is very important. Next slide, please. So key takeaways. We know that now we have a newer subset of patients who benefit from TDXD. HER2 low and HER2 ultra low are actionable. We should know the definition of this and we should report it as per ASCO guidelines. I mean, we should get our pathologists to report it as per these guidelines. And I think we'll all share what has been shared here with our pathologists, along with the reporting pattern, the footnote, and all the details of the pre-analytical factors. Next slide, please. Yeah, thank you. So I know it was a pathology class, but it will help in reinforcing our pathologists to report better. Thank you.
Thanks so much, Mansi. Very informative. But just one question.
Yes, ma'am. I can't hear you, ma'am.
If we have given neoadjuvant to a HER2 positive patient and there's a residual disease, and now for some reason we repeat HER2 and it comes negative, what would you do? Would you continue adjuvant or how would you?
Right. So I think, ma'am, this is something which we are doing off late now because of the emerging data. So what I would explain the patients is the HER2 clone which has responded. So obviously we have to continue because there might be other micrometastatic sites where HER2 clone is still positive. But when it happens the other way, we obviously, if a negative becomes positive, we obviously add HER2 targeted therapy, but we don't deduct it if it becomes negative. That's what I do, at least.
Yes, thanks so much. So our next topic is clinical evidence and evolving role of Trastuzumab Deruxtecan across HER2 spectrum. Over to you, Dr. Sai Vivek. Dr. Sai Vivek is a consultant medical and hemato-oncologist at Aster Hospitals at Bangalore.
Thank you, ma'am. I'll start sharing my screen. Yeah, so I hope my screen is visible and I am audible. So I think after those two excellent and extensive talks by Dr. Mansi and Dr. Vishwanath sir, we move on to the clinical usage of anti-HER2 treatment and especially Trastuzumab Deruxtecan across the HER2 spectrum. Some of the slides that Dr. Mansi reiterated multiple times, I'll be skipping through them now that we all know how to identify HER2 0, HER2 1+, HER2 2+, and even ultra low very clearly from the talk given by Dr. Mansi. So I think this would be the agenda for the evening, or rather the presentation. So we'll start off with this important slide. So I'd like to break this down into numbers. So all of us know if you have 100 breast cancer patients, 15% of them would be HER2 positive and 85% of them are being termed as HER2 negative. So in those 85% of the patients, data is clearly showing that 60% of that 85, so close to 45 to 50 patients are still targetable with anti-HER2 treatment. These are the patients post 1 or 2 lines of therapy. They could be hormone positive, post CDK4/6 and endocrine, or triple negative post 1 line of therapy, did not have good targetable agents. But these 45 to 50 patients are now coming under the spectrum of usage for anti-HER2 treatment. So the landscape is rapidly evolving, and this is I would say, a huge shift in terms of the number of options that we have available for our previously taught HER2 negative patients. So 1/3 of our patients never reach the third line therapy, as with many cancers, little lesser with breast cancer. As we move from the first line to the second line therapy, around 15 to 25% of them, because of various factors, it could be performance status, it could be visceral mets causing decompensation of that particular organ, do not go on to receive the second line setting. And from the second line to third line setting, it is almost around 35 to 40%. So this tells us that when we are using the first line therapy, it has to be the most effective, and of course, the most safest therapy should be used in the first line setting, and that applies even for the second line setting. So the standard of care in metastatic breast cancer, HER2 positive, which has stood the test of time, is our Cleopatra study. So we have discussed this study multiple times, so I'll just briefly talk about the overview of it. The latest readout, we know the median overall survival is 56.5 months versus 40.8 months. That's a delta of close to 16 months in terms of the overall survival. And before the advent of Enhertu or Trastuzumab Deruxtecan, a novel ADC, we all used to use TDM1 based on the data from the Amelia study. Again, a well-conducted, large study. Here, the median overall survival was 30.9 months versus 25.1 months, a delta of 5.8 months. So as we go from the first line to the second line itself, there was a large decline in the efficacy in terms of both PFS and overall survival, which is clearly seen in this particular slide. So the median PFS decreases from almost around 6 to 7 months by 50% to around 3 months. So we did not have a good second line treatment option post the excellent data from Cleopatra in metastatic breast cancer patients who are HER2 positive. That was definitely an unmet need. There comes our Enhertu, that is Trastuzumab Deruxtecan. It is a HER2-directed monoclonal antibody, and it provides a targeted delivery of a cytotoxic agent, which is a topoisomerase 1 inhibitor, that is Deruxtecan. It is a tumor-selective cleavable linker, which goes on to say that it attaches the payload to the antibody. The linker payload is stable in the plasma. Only when it reaches the tumor microenvironment, it is then cleaved and the antibody goes into the cells, and this also has significant bystander effect. And comparing TDXT versus TDM1, we know the ratio of drug to antibody is much higher in TDXT, and the membrane permeability is there for TDXT, hence the bystander effect, and the payload is different. It is a very potent topoisomerase 1 inhibitor in TDXT, and the linker, it is a stable linker for TDM1 and a tumor selective cleavable linker for TDXT. So everything is almost different in terms of the cytotoxic class, that is, the payload is different, the broader bystander effect, and a very targeted localized payload release are the differentiating factors of TDXT versus TDM1. So moving on to the current treatment algorithm for HER2 positive MBC, the first line, it is fast evolving. We know that Trastuzumab Deruxtecan plus Pertuzumab are quickly moving in as per the Destiny Breast 09 study, but still THP, as per the Cleopatra data, still is the category 1 preferred recommendation for first line metastatic setting. In the second line setting, we have TDXT, which is the preferred recommendation, and TDM1. So we are going to quickly go through the trial, which all of us have seen before multiple times. That is the Destiny Breast 03. This was the entry of TDXT into the second line setting. So the patients could have received trastuzumab and a taxane, but no prior treatment with TDM1. Around 260 patients were randomized into TDXT versus TDM1, which was then the standard of care. The primary endpoint being PFS, and the key secondary endpoint was overall survival. So we started getting the data. Now we got readout last in 2023-24. When we got that particular thing, we know the median overall survival was 50.9 months in the TDXT arm versus 35.4 months in the TDM1 arm. So that translates to around 15 months or over a year advantage in terms of overall survival. And there might be more number of patients who have moved on from TDM1 into TDXT even in the third line setting if the crossover was allowed. So 24 patients in the TDXT group and 2 patients in the TDM1 group remained treatment even at the final readout. So this particular hazard ratio of 0.33 was never seen in the second line setting in breast cancer, which goes on to show a 67% reduction in the hazard of progression. And even at 2 years, almost double the number of patients at 53.7% remained progression free versus 26.4 in the TDM1 arm. So 67% reduction in the hazard for progression and a 13.7 months benefit in terms of overall survival at nearly 5 years is what we know with TDXT. So this is the TD Destiny Breast 03, which made sure that TDXT was approved in the second line setting in HER2 positive MBC. So the PFS2, which again is a good surrogate marker for the efficacy of a drug, the PFS2 for TDXT was 45.2 months versus 23.1 months for TDM1. Nearly 22 months difference in PFS2 also goes on to show that the TDXT is highly efficacious in this particular setting. So 52.6 versus 42.7 months. So the adverse events, as we use TDXT more often, we are starting to better dose adjust and screen for interstitial lung disease or cardiotoxicity, which are the most feared toxicities of TDXT. Apart from that, cytopenias, nausea, vomiting, and fatigability are the side effects that we generally see in the clinic, and we are quickly learning to manage them. And with a drug with such good efficacy, I think all of us with time we'll end up managing it and starting at doses which we are comfortable in the future. So 3 plus, there is no doubt, HER2 3 plus, we know second line setting, and quickly coming to the first line setting is TDXT. Most of the metastatic breast cancers at some point will be destined to receive TDXT, and there is no debate in terms of that particular question. Now moving on to the HER2 ultra low and low. I'm not getting into the testing and the labeling of HER2 ultra low and low, which has been clearly discussed by the previous speaker. So this particular 45 to 50 patients are what we are going to be discussing in the next few slides. So this HER2 IHC and the magnifications has been discussed. And when we look at hormone positive and HER2 negative patients, we have an excellent first line option with endocrine therapy plus CDK4/6 inhibitor. And once we go on to the second line and beyond setting, the median PFS drops drastically to around 6 to 9 months in the second line and 4 to 8 months in the third line setting. So here, this becomes another unmet need, which probably could be solved by the Destiny 06 trial, which included patients with ultra low and HER2 low positivity. So Destiny Breast 06, again a phase 3 trial with a large number of patients, 436 in the NHER2 arm and physician's treatment of choice around 430. And here patients who needed to receive 2 or more lines of endocrine therapy plus targeted therapy for MBC, or 1 line of endocrine therapy plus targeted therapy and progression within 6 months after starting the first line endocrine therapy and CDK4/6 inhibitor, or recurrence less than 24 months after starting adjuvant endocrine therapy. So they were looking at primary endocrine resistance or patients who had bad biology on the first line setting, patients who had HER2 IHC1 plus, sorry, with patients who had HER2 IHC1 plus or IHC2 plus ish negative or HER2 ultra low MBC were randomized in this particular study. And as we can see here, in the treatment arm with TDXT, there were 17% of the patients with IHC 0 with membrane staining, that is ultra low, well balanced between both the arms, I would say, in terms of the disease characteristics, in terms of prior treatments, everything. The trial was more or less well balanced. Most of the patients received 2 or more lines of therapy for hormone positive MBC, and around 50% had also received chemotherapy in the non-metastatic setting. So this trial clearly So this trial clearly showed a benefit of using TDXT in the HER2 low and ultra low patients, where there was a PFS benefit of 5 months and a quick and early separation of the PFS curves is what we see. Within around 50 to 60 days, there is quick separation. The separation is maintained. That gives us a hazard of 0.62 with a 38% reduction in the hazard of progression. And as we saw in the initial few slides, we saw that the second line PFS was around 6 to 9 months. And here we have almost doubled that historical PFS of 6 to 9 months to 13.2 months by using TDXT in the second line setting or third line setting in this subset of patients. The overall response rates were double at 62 versus around 35%, and the median duration of response was 14.1 months. So again, if you look at the forest plot here and look at the subgroups, what we can see here is nothing much to take away. Most of the subgroups really benefited, but if we started using it beyond after the first line setting in the 147, which is not a small number, there was definitely the hazards dropped to 0.45. So the primary endocrine resistance or bad biology in the first line setting is only something that I can take off from this particular slide and probably see if we can incorporate it into our practice. Such patients, we need not hamper around for finishing the second line. As per the inclusion criteria, they can be offered TDXT and they do show excellent benefit with a hazard of nearly 0.47. So if we move on to the HER2 ultra low versus HER2 low, this is the left hand side is the overall study population, and in between we have the HER2 low, and on the right hand side we have HER2 ultra low. HER2 low had the maximum benefit with a hazard ratio of 0.62. And when we look at ultra low, yes, there is separation of the curves, but it is statistically not significant as the confidence interval crosses 1. Numerically, yes, but statistically, no. But for HER2 low, yes, statistically and clinically meaningful benefit is what we are seeing with the PFS curves. The response rates, all the three groups, or rather low and ultra low, had equal response rates at around 65%. The adverse events, we all know, I'm not going to go into the depth of adverse events. So Destiny Breast 06 gave us an evidence to use NHER2 in the second line and beyond settings in hormone positive, HER2 negative MBC patients, and 20% of the patients had serious adverse events, and we definitely are learning how to manage them. And dose reductions, around 25% of them required dose reductions and 50% of them required dose interruptions. So we need not be worried about the chemo cycles getting delayed. I think 8 weeks to 10 weeks once doing a HRCT is what most of us are doing in the clinic. And only 15% of the patients required discontinuation. And the most common adverse event was ILD or pneumonitis, which was seen in 2% of the patients. So the last couple of slides. Now we have excellent data from the Cleopatra. We have seen the Destiny Breast 03. So, and Destiny Breast 09 is telling us start using TDXT plus pertuzumab in the first line setting. And the thing here is we still haven't gotten the data for single agent TDXT from the Destiny Breast 09. So that is still not seen by us. So how do we sequence in for metastatic breast cancer patients who are HER2 positive? So PIK3CA could be one biomarker which we can use. Here we can see for PIK3CA wild type patients, the overall survival with THP is 73.1 months. And for the PIK3CA mutated, the overall survival drops to around 50 months. That's almost a 2-year drop in overall survival. So the benefit of PIK3CA is now, I think, getting more and more important. We need to start testing it in multiple settings, at least to prognosticate both in hormone positive MBC and HER2 positive MBC. I think having the status of PIK3CA might at least prepare us to decide on which treatment to use in the first and second line settings. So the HER2 DX assay is another way of doing it, which I don't think we are using much in the clinical practice, but using PIK3CA could be something which we can incorporate going forward into our clinical practice. And as with every cancer, ctDNA is quickly coming in terms of us learning how to predict the response and the progression. It is still, I think, a little too early for us, but I think the future is going to be ctDNA. So let's wait and watch in terms of how the data is going to evolve. But there is early data coming in that the clearance of ctDNA can predict in terms of the prognosis and how the treatment response is going to be. So that's my last slide. Thank you. And back to the organizers.
Thanks so much, Sai. We'll move to the next topic, that is next generation ADCs and breast cancer. This topic will be taken care of by Dr. Satheesh CT, who's a senior consultant medical oncologist at HCG Group of Hospitals in Bangalore. Over to you, Satheesh.
Thank you, madam, for giving the opportunity and for even AstraZeneca for this opportunity. I think we are hearing from beginning from you and Sai and Dr. Vishwanath and Mansi. They're given a foundation about ADCs and different of aspect they use in a lower to 3 plus amplified. And my slide is visible.
Yes, sir.
Yeah. Okay. Let's see that because we have a various different type of ADC now, definitely other than cytotoxic drug, immunotherapy and target therapy, now ADC is a really emerging evidence in the treatment of any cancer, including even breast cancer also. Let me go through that what are the ADCs what we used already, that previous speaker already highlighted about the TDXT that they're all talking in that too. Now, I'm going to cover about the other ADCs. What are the ADCs are there, and what are the importance of this? Because we have so many ADCs, we are getting confusion. Which one you have to do? Any ADCs there that there are the efficacy, anything like a characteristic and a benefit, all the things are depend on the what are the payload mechanism of action, what is going to be used in the different type of ADC, and also the drug to antibody ratio, that is also very very important, and the tumor selective cleavable linker, if there that is selectively is going to target the tumor targeting cells, and also the most important is the evidence of bystander anti-tumor effect. If these things are there, definitely that ADC is going to have work in a better, we might use it because many of us we might use one of the ADC in one time, and we might come with a resistant mechanism. We might have to come with we have to use other different ADCs. Definitely, we have to think about that. What the different cross resistant between the different ADCs, and when you have to use and how to use it. This is the one thing challenging for us, because still we are struggling, because in HER2 positive we are like in a dilemma of whether I have to use a TD1, TDM1 we have to use it, a TDXT front, or like in adjuvant setting now. that evidence data is there for a TDXT is favorable. Dr. Sai is presented. Like definitely this, if you fail to determine whether which one to use it again, how we have to go through that. These are the challenges are there. This is a timeline of how ADC innovation has happened in breast cancer. It was started from 2013 TDM1 in a pre-treated breast cancer. Later, like it's come in adjuvant TDM1, like adjuvant treatment in the HER2 breast cancer. And next, like we got a TDXT in 2019 and pre-treated heavily that HER2 positive. Like this, like Satheesh has come, and it was initially come in a pre-treated, and later like it's coming in earliest stage in a first line, like those second line data has come. And like this, like similarly the TDXT is coming in the low HER2 MBC, and also the again now is going for ultra low in HER2 positive, that MBCs also, and heavily pre-treated like hormone receptor positive also we try to go with this. Coming to these three ADCs are there, Dato-DXT and Trastuzumab DXT also is there, and Sacituzumab Govitecan. We have three ADCs is there, like only these, the one is available other than the TDM1, HER2 positive. These two drugs are there in a clinical trial, or we are getting on sometimes compassionate background. Otherwise, you have to get from the import from the outside the country. It's a challenging for us because we have a two ADCs that are going to target a TROP2. This is HER2. Because the main thing I told you previously, the first slide was talking about the payload. That is almost like they are all three are a topoisomerase inhibitor. TDXT is there in both the thing, but here is SN38 is activated the Heterogeneity component actually. Drug antibody ratio is less here and is the highest for the transformer TDXT compared to the other molecule. And the linker cleavage is enzymatic. Here is a pH dependent. This is one thing. That's why is a pH dependent and an enzymatic the degradation will happen. That's why it is unstable in plasma compared to the other the ADCs what like a DXT like they are related. They're stable, and bystander effect definitely is seen in the DXT that Deruxtecan what we have the bystander effect is there, but we don't see in the Sacituzumab. And DLT is known actually, that is a Dato-DXT, the stomatitis and regarding mucosal inflammation, like a maculopapular rash was seen, but we don't see. But Sacituzumab with the neutropenia is there. We know that this is the one of the thing we have a HER2, one of the target like we are doing in the amplified or sometimes mutation also, sometimes like we low HER2. That is the one of the common thing what we are trying to use it failure to the first and second line treatment in lower HER2 metastatic breast cancer, and even we are using adjuvant and early breast cancer also. This the next important ADC is the targeting the TROP2. This one of the transmembrane glycoprotein primarily expressed in the epithelial tissues. It can be this promotes a cell proliferation and survival invasion from metastasis. That's why those who have a high expression of TROP2 definitely associated with the disease progression and proliferation metastasis. If you have that, if the TROP2 positive there is the prognosis is very poor and even short survival in the breast cancer, even other cancer also. We have a data for this phase 3, the TROPIC-02 study, that is with the Sacituzumab study here. You can see there is an improvement in that progression-free survival rate when compared to the treatment of physician choice, especially recurrent in hormone receptor positive HER2 negative breast cancer. We have data for even transformer DDXT also is there. But here you can see that PFS is like you can see 5.5 versus the 4 months is there, and OS also is a significant like as improvement is there. You can see that it can be used in the recurrent inoperable hormone receptor HER2 negative cases. You can use it. We have other ADC that is like you can see that the difference like the benefit, does it differs in the low HER2 or HER2 score 0? Because low HER2 like because we have a transformer DXT also is there transformer and TDXT, but here like the low HER2 low or like to 0 still is going to work similar overall surrogate in these both the cases, especially hormone receptor positive HER2 negative metastatic breast cancer. We have one more ADC that targeting the TROP2, that is a Tropian Breast 01 study. Here, like we have the Dato-T and DXT versus the investigator of treatment of choice will be there here. Here, you can see that is going to have the good PFS and even OS also. Like you can see that OS is like not significant here, but only the PFS benefit was seen here. And the one thing, the characteristic of these ADCs, their own special toxicity. If we come into the data.txt, you can see the main toxicity that what we see, the dose limiting toxicity, the oral mucositis. I'm using this drug in the clinical trial in the lung cancer. You have to use prophylactical steroid based the mouthwash. You have to prevent the mucositis, and also ocular toxicity is a periodic eye checkup from the baseline. It is very important. Can have even ILD also, but not as high what you see in the Trastuzumab Deruxtecan. And you can see other nausea, vomiting, and characteristic of other all ADCs are there. The main thing is mucositis is very important. You can give maximum almost you can 60 to 70% you'll see. But the main thing is that the prophylactic use of steroid containing mouthwash is very important. And sometimes they'll use a ice piece like ice water. Other thing you can try to cryotherapy also can use it. That also helps to reduce the mucositis. Next is the second other, you can see up to 40% of ocular toxicity can be dry eyes, keratitis, and sometimes can have blepharitis also can be there. That ophthalmological periodic checkup is very important. This is the thing, the how we sequence the ADCs in the hormone receptor in metastatic breast cancer. We'll see that what is the possible way of endocrine therapy. We try to do first line to even 3 lines also, but still desperate to find out hormone therapy to control. But still we are going to get the failure rates. And we have a ADCs, that is we have a well-established data that is we heard from the previous speaker. Trastuzumab Deruxtecan is very important. Actually, we have from the TB06 study is going to tell us is have a good efficacy. And if you fail to that, we can use, if you don't have the option also, like, because these drugs are not available in India. This drug is available already approved and is available in the with the drug support app also is there. We can use it. But sequencing can use it. If you use this, you can go for a. I think better you can sequence in different way. I feel because there are both similar synergetic toxicity. And if we go TDXT, if we use that Satheec, we can use it. If we have Satheec, we can use that data.txt. You can do like that. You can use it. Some the degree of cross resistant you can see between the ADCs. That is very is important. We are going to see that. And later we'll go into, because it's a learning curve for us. We are not being used actually. We have just stuck up between the TDM1 versus the TDXT because other ADCs are not available. And these ADCs are available. Definitely we have to learn actually sequencing of which ADCs we have to use, and definitely we have to learn the cross resistant actually. Among this, the patient who treated at TDXT, that is going to be try to have a longer PFS compared to the chemotherapy when compared to other ADCs like Satheec and even data.txt also. And this is the one thing, like those patients with the low HER2, you can see that when you're using first, you can have sequencing of ADC. It can be Satheec or transmembrane NR2 also you can use it, or NR2 versus T, that is Satheec. But here, like you can see, which is the first ADC we try to use have a highest benefit. You can see in the first like ADC can use the Satheec here first line in hormone receptor positive or even hormone receptor negative. Also, you can see lower 2 cases. Still, this is the best response compared to the second ADCs. This is the sequence. But if you use the other sequence also, still, which is the first ADC we use it, the same thing they try to have the best benefit. And when you're using that will be cost resistant will be that's what we have to understand how to overcome all the things. That there is some study data, some many combination thing or immunotherapy or anything we have to learn actually. This is a potential the sequencing algorithm what we use it actually hormone receptor positive HER2 the low or like ultra low. You have exhausted all endocrine therapy. We may use a preferred one is the what is available is the TDXT. Otherwise, treatment of physician choice, we may use a taxanes or we may use the capecitabine. We may use it in a low burden disease. Otherwise, we may use other the cytotoxic drug is not exposed. Or you can use a TDXT, data.txt is not available. If it's available, we can use our Satheec also. This is one of the things we can use it. But among these, Trastuzumab, the NR2 is one of the thing preferred ADC in this, unless like a HER2 is null or like a previous history of ILD is there. Choice between that data.txt Satheec is based on the different toxicity profiles, all the thing with the previous treatment. always prefer the treatment with the ADC or the chemotherapy in this setting, compared especially those with the brain mets, because we may not have a successful story what we get in how we used to get in the ADC compared to the chemotherapy. That we have to learn. Consider switching the strategy between the chemo or ADC. We have to learn, because always there is option of clinical trial is there, but availability of the clinical trial also in India with for our patient also very important. It may be available in Western country, but may not be available. But we'll definitely in future we are going to learn with availability of these ADCs how to sequence all those things. Next, coming to the triple negative metastatic breast cancer, there is a lot of unmet need at TNBC. Because PD-L1 positive is one of the marker for using the chemoimmunotherapy in the first line. The median, the 5-year OS is almost up to 15%. You can see 70% may not be candidate for a first line immunotherapy because various reason, maybe PD-L1 may be negative or may not be fit for that. When coming to second line, only 50% definitely they may not able to go to beyond the first line treatment. There is a data is there here. The Satheesh in the previously treated TNBC, that is more than 2 or equivalent to the 2 lines of treatment. You can see here the response rate is CR is like CR is up to 10%. Partial response is up to 72% compared to the treatment of physician of choice. The dose what they use is here the day 1 and day 8 schedule, Satheesh Deruxtecan, the 10 mg per kg, and every after that is a 3-weekly cycle that will be used. We have to take care of the thing. Myelosuppression is one of the thing. Diarrhea, that's one of the thing what to try to see with the Satheesh. The PFS is definitely it is very the important is a significant benefit here. What we see here, PFS benefit and OS also. This is a successful story in the TNBC. We have other the data is there like that is a Satheesh TMT, that is a Therapeutic. This is the Chinese medicine. The definitely how we have Chinese IO drugs. We may see this drug is going to be available. It may be competitor for the other ADCs. You might see that successful, like the data is very impressive. This drug, the dosage is the 5 mg per kg, 2-weekly schedule, not a day 1 day 8. The 2-weekly schedule will be there. That PFS is very impressive. That is a 13 months. You can see that is very impressive. That is the one thing here. And OS data also is very impressive. And compared to the hazard ratio is both PFS and OS is significant compared to the treatment of physician of choice. Coming to the tropion pan tumor 01 study, that DATO-DXC you have a data, and not only breast cancer, you have a pan tumor. You can see TNB is also part of the pan tumor subgroup. Actually, you can see like median PFS is almost 7.3 months. You can see here, and there is a data is now combining both this like ADC with the sometimes you want to use immunotherapy in all the case chemoimmunotherapy. We have the data like is there like because immunotherapy cannot be used because various reasons can be PD-L1 negative can be there, or maybe even though PD-L1 positive they may not be eligible because of the contraindication to use a IO drug. Here the data is there. Satheesh was compared with the immunotherapy ineligible patients like with the chemotherapy. You can see here Satheesh was compared with the chemotherapy. You can see there is a direct comparison. You can see still is impressive. It is going to cover this because if you go that chemoimmunotherapy is the standard of practice compared to Satheesh is that we have to see that whether to compare or not. Okay, we don't have a data like that. Like this is the data without IO drug with the only chemotherapy. The PFS is 9.7 versus 6.9 months. And is impressive data with the consistent maintaining the PFS, and the duration of response also scores better over the chemotherapy with the Satheesh. Coming to the toxicity characteristic of this one, most likely you will try to see the nausea, vomiting, and alopecia. You can see the diarrhea as one of the commonly we'll try to see. Sometimes we try to see altered liver enzymes. These are things that are manageable. Myelosuppression is one of the things we try to see with the Satheesh. Coming to the other ADCs with the breast cancer, that is tropion breast 02 study, that is the DATO-DXT in a first line TNBC. You can see here the patient can be locally recurrent or inoperable metastatic TNBC first line, no chemotherapy target therapy is used in the first line. No immunotherapy is used here. Dato-DXd, the dose what they use is the 6 mg per kg is a 3 weekly versus the ICC, that is a investigator choice of treatment. You can see that they stratified based on the PD-L1 status, all the thing. Like duration of the primary endpoint was OS and PFS and toxicity profile. You can see here that the baseline characters are well matched. Coming to the primary endpoint, you can see that the PFS, you can see that at the 12 month, 18 months, it's going to be impressive. That is the median PFS is 10.8 months versus the 5.6 month. The statistical significant hazard ratio is 0.57. Coming to the OS, you can see here the OS data is hazard ratio is 0.7. The graphs are separating. You can see here median OS in the first line setting is a 23.7 months versus the 18.7 months. It is Dato-DXd demonstrated statistically significant and meaningful improvement in the OS and also even the PFS in the previous slide. Coming to subgroup analysis, irrespective of the age and is the performance status, you can see up to 1. And it is whether it's a de novo metastatic disease or like a disease-free interval in the previous neoadjuvant treatment within 12 months. Aggressive disease versus more than 12 months is going to benefit it. PD-L1 status, even irrespective of PD-L1 is going to work. Brain mets also and liver mets also. And coming to the OS benefit, you can see it's going to see all the subgroup except you can see here the numbers are small from the US and Canada group. Actually, rest other things are going to favor towards the Dato-DXd versus the investigator of treatment of choice. Coming to the response rate, definitely is more than doubling in the response with the ADC compared to the chemotherapy. And you can see that there is an increment in the partial response and complete response when compared to the chemotherapy. Definitely is confirmed. Overall response is better, is double the investigator of treatment of choice. And duration of response also is very, very significant. You can see 12.3 month versus the 7.1 month. That is a delta of 5.2 month with improvement to the use of ADC. Coming to the toxicity, previously I told that is the grade 3 toxicity and treatment, the adverse event, in serious in SAEs, I can see. Here you can see the dose reduction. You can see here also with this Dato-DXd also. That is the doubling in the despite of dose reduction, all the thing. You can see that the total duration of treatment is also still consistent with the Dato-DXd. And even the survival rate also, irrespective of even grade 3 toxicity, dose reduction is there, interruption is there, still they're able to maintain with this in spite of the dose reductions. But you should learn actually how to when to do the ADCs, the toxicities of the thing. These are known side effect of Dato-DXd is the I told you previously stomatitis and ocular problem, and also you can see myelosuppression also we'll try to see with along with the diarrhea. Coming to the characteristic side of this Dato-DXd is the oral mucositis. You can see that the grade 3 toxicity was up to 8%. Ocular toxicity was also there important, and ILD also was seen. But they are less when compared to the ILD is not very severe. What we see in the Trastuzumab and NR2. But you can see with this Dato-DXd also, ILD also one of the things you should watch. We cannot ignore it actually. Summary of this study, TROPION-Breast02 study. It is a phase 3 randomized study. You can see that a TROP2 directed is one of the first line Dato-DXd, the TROP2 directed ADC versus the traditional chemotherapy. What we see that in a metastatic triple-negative breast cancer, in whom that the immunotherapy is not option. There you can is where you try to have the aggressive biology. They're this is the one of the things the ADC is there, that is the Dato-DXd is there. It's right. It's going to meet both the dual endpoints, both PFS benefit and OS benefit is going. It has shown in the both the benefit with the safety profile. They're all manageable, but you should learn how to manage this the toxicity, how to prevent that mucositis and ocular problem, and with the managing with the follow up with the ophthalmologist. We have one more interesting data, that is a combination treatment. We have talking about the single agent ADCs. Now they are combining with the IO agent. This is one of the first line treatment in a metastatic triple negative breast cancer. But they use the pembrolizumab with that sacituzumab. We can see the first line data versus the chemo with pembrolizumab. This was one of the standard treatment what we use right now. But only thing PD-L1 should be positive. That is the score should be more than 10. That is one of the cutoff factor for the triple negative breast cancer. You can see yes, PFS is definitely shown an improvement at the 6 month and 12 months. It was consistency is very important, statistically significant. OS primary, the endpoint of this one OS is not met. That is 81% of patient. There is a subsequent discontinuation with after the chemo, pembro, they received the sacituzumab. That's why the overlap is there, crossover is there. That's why the primary endpoint was not met. The PFS was very important here. Duration of response with you can see here like a important 16.5 months versus the 9.2 months. The graphs are well separated. You can see the more important is the complete response, partial response. You can see very impressive, and the progressive disease are less when with this sacituzumab. It's a chemo-free regimen. You can use it whenever people they don't want chemo, but ADC also is acted like chemotherapy, and alopecia also is there. But you should learn how to use this drug and stop toxicity. We have other one more like combination study that is the Dato-DXd with the Durvalumab in the triple negative breast cancer. Can use this one of the studies there like you can here also you can see that the PD-L1 positive cases, not all the cases, PD-L1 positive triple negative breast cancer was used here, and they tried to see the improvement in the tumor response PFS, and the overall response was noted, but needs still follow up actually. And there's one more interesting study that is Chinese study, that is a sacituzumab TMT, that is a Deruxtecan. The phase 2 data you can see here is this is without IO combination. It's a single agent in a first line and metastatic TNBC. That also is giving the impressive data. The overall response rate is almost 70%, irrespective of the PD-L1 status. You can see here because we have to have the PD-L1. If the positive is there, we'll try to combine with the IO with the sacituzumab in the first line data. You can see that almost data is like this PFS data is equivalent to the combination of sacituzumab govitecan with the pembrolizumab. That is one of the impressive days. We cannot compare cross comparison between the phase 2 versus the phase 3 data, but is a very impressive median PFS is 13.4 months actually. You can see here, irrespective of PD-L1 expression. That is very important actually. And the toxicity of this one, they're all manageable. Like main thing is a myelosuppression. There's a one with this sacituzumab and Deruxtecan, and blurring of vision, all the things. They're all manageable. The ongoing investigation with the top two agents, the future you can see here, like you can see the first lines the Chinese that is ADC, that's sacituzumab TMT with plus or minus immunotherapy is going to come actually, and this already data is there actually, that first line data DXT with the Durvalumab plus or minus with the PD-L1 expression. You can see that the data is also impressive. Like we have to require a more long-term follow-up of this one, and we have a data data DXT with Durvalumab in the stage 1 to stage 3 TNBC with the residual disease after the neoadjuvant. This is a very impressive thing. This is going to be because we have a how we titrate the adjuvant treatment, post neoadjuvant treatment in a HER2 breast cancer. Like this is one of the important treatment. We have a only capecitabine or olaparib is in a residual disease, or a continuation of 1 year of immunotherapy. What we do, this data is going to be, if comes means it's going to be impressive. And we have that other data is coming in the adjuvant high risk TNBCs. Other thing, this the future era is going to era of ADCs in a various setup actually. Neoadjuvant, adjuvant, all the things is going to come. The one thing is there, like ADCs transform the breast cancer treatment in nowadays, like in a various factor, drive the various factor for a decision making. One thing is whether a clinical data is available to improve the PFS and OS data along with the safety profile and response rate. That's one of the thing everyone look. Dosing schedule, because not easy, like we have frequent visits means no one likes actually. The dosing schedule is also should be comfortable. Optimal sequencing is also important. Now we have the various ADCs coming. We may use a one ADC first line, that will be ready for a next future other ADCs in a maybe if chemo followed we may use in a various subsequent sequencing can be done, but you should learn the how to overcome this cross resistant actually and tolerability, because sometimes you have a using the similar type of ADCs. So I use the NR2 followed by if I use a dato DXT, because is it a overlapping of toxicity of ILD anything? You should be careful actually that you should learn. We'll be learning actually that's what is one thing. And the good thing is about the quality of maintaining quality of life is very very important, because the data DXA have mucositis is there, Satheesh a lot of diarrhea, myelosuppression is there, and also the tumor burden and all over the drug, and also the in India what we practice the cost is the one thing, PAP program, those things that definitely they determine the treatment of this ADCs. And overall this the ADC anything is there, try to see the linker stability, the plasma stable or unstable. Sacituzumab is unstable because of the pH is one thing deciding factor. Cleol linker is there. Payload I already told you that. And Deruxtecan are like the SN38, and those things are there. And antibodies which is going to target the HER2, TROP2, your nectin antibody also is there, and various tissue factor also is going to come actually. And we're going to have an era of ADC in various antigens. And also next we are going to see the various newer drug is there, like the drug ADCs is going to come. We are going to learn the duration capping and the cross resistant actually, and we are going to learn in the future. To conclude, emerging ADCs is under investigation for metastatic breast cancer across a different type in a different settings. The component of ADC differs across the spectrum, resulting in a various mechanisms of action. Innovative, the molecular designing that's implemented in the next generation of ADCs, they have potential to tackle the drug resistance. That's what is very, very important, because we have this, but you should the drug what is going to a new drug to tackle this drug resistant and tumor heterogeneity and toxicity. If these things are there with a good safety and efficacy profile is there, that is going to be winner. We have that definitely limited ADCs for a clinical use. We are learning actually, and definitely the many molecules are we are yet to use because of the availability of the drugs. I'll stop here. Any questions? I'm happy to take. Thank you, madam.
Thanks so much, Satheesh. It was extremely informative. I think we are very short of time. We have already exceeded some 10 minutes from the
Yes, ma'am.
actual program. We'll go to the moderation, the panel discussion. This will be led by Dr. Rajeev Vijayakumar. The topic is sequencing ADCs in the breast in the current era in breast cancer. We have panelists Dr. Supreet, Dr. Vijayakumar, Dr. Sampath, Dr. Prahlad, and Dr. Annie Ba. So over to you, Rajeev.
Hi, good evening. Are my slides seen?
Yeah.
Yes, sir.
Hi, first of all, thank you, Dr. Niti, madam, for inviting us to this, and thank you, AstraZeneca, for educating us extensively on the durandars of the antibody space, of anti-HER2 space. We have so many drugs. It's going to be so difficult navigating from point A to point B. It's going to be very difficult, at the same time very easy. The easy thing is to put Deruxtecan for everyone, and the challenging part is going to ensure that to whom do you give what. So may I just hope all my panelists are there. So when to introduce ADCs into HER2 positive MBC? Someone who's been listening to Vishwanath, Mansi, Satheesh, and Sai would be easily able to answer all of these. It's not much of work that I have to do, but nevertheless. So, well, according to the current guidelines, NC and ESMO, where do you see antibody drug conjugates positioned in the standard treatment? It's like basic early small little ball, trial ball to start off today's cricket match. So if I ask my dear friend, the Colonel Kaushik from Command Hospital, Kaushik, are you there? Annie? Anyone
Hi,
can
sir.
take this question. Hi,
Yeah.
Annie.
So, yeah, for me, Antibody drug conjugate in a metastatic will come in second line. First line, Cleopatra is their standard of care with Pertu, Trastu, and a taxane. So that doesn't budge from its first position for me. TDX would come in the second line.
Okay. Anyone else? Prahalad, would you have any other difference of opinion, please?
No, sir, I agree with Dr. Annie. I think we have a Cleopatra in the first line and TDXT in the second line. Probably those who have brain mets, we can consider using Destiny 9 in the upfront setting.
Upfront, you'd like to use Destiny 9 in that kind of setting, or would you want to go in for HER2 climb in that kind of situation with brain mets? Suppose someone comes to you with metastatic upfront metastatic brain mets, then would how would your thought process change? Would you want to do tucatinib upfront, or would you go and get for Cleopatra? There is some amount of data which says that there is brain penetration with Trastuzumab per2 as well. Or would you stick to that, or you would say that no, let me hit harder because my
I think
my
as
quality of life is
as of now, it is Cleopatra only, sir. I think regularly, I think most of us are practicing. Probably, I think we should wait for the long-term results to have the final answer.
Yes, of course, we have DB9, we have good PFS data. OS data is yet maturing. The PFS data seems to be like fantabulous. So, well, yeah. Yeah. So then, Dr. Sampath, are you there? The big boss of Bangalore.
Yes, sir. Yes, sir.
Yeah,
Sir. Tell me.
So, what are your thought processes, sir, on this?
Tell me. Yes.
So, what would you like to use in sense that in the HER2 positive brain mets, field mets, and like hormone positive, hormone negative? Any thought process difference? What would you like to use? Let's consider you have a hormone ERPR, HER2 positive brain mets, extensive mets, sick patient. What would be your therapy choice? Let's consider she's symptomatic, so you've given radiation also.
We've given good brain radiation. Is a driver mutation will be
ERPR positive, HER2 positive, brain metastases.
Yes. So in those cases, 2 positive is the driver mutation. I'll start with the anti-HER2 therapy. Yes, we don't know. I'm going to start a TDX2 offerently in these patients. I have to think of.
What would you like? What was your therapy of choice? Are you going to do plain Trastuzumab, Pertuzumab, TDM1? Because like now we have data that showcases that TDM1 crosses the blood-brain barrier more often than Trastuzumab, Pertuzumab. So would you like to move your needle towards TDM1 in this now? Because the first upfront treatment naive patient.
Like that, I think we can use offerently the TDX2.
TDX in those kind of situations, okay, you like to use TDX. And what about your hormone therapy partner? What would you like to use? Fulvestrant, letrozole. What would be your hormone therapy partner?
Hormone therapy partner, I'll go with the letrozole or anastrozole.
You'd like to use abemaciclib or ribociclib or palbociclib along with it? Triple positive?
Triple positive abemaciclib. That's what I said before only. It is a HER2-driven disease. So if it's a triple positive brain metastasis, it's HER2-driven. That is, I don't think so. It matters more. I will go with the anti-HER2 blocker, then with one aromatase inhibitors.
Very well. Like now, I'm sure that like you can see over here that the Patina trial, which has come, which has showcased some increased benefit in OS and PFS benefit when adding palbociclib. We don't have that particular data for ribo/abema right now. It's yet there are trials going on for that as well. But for palbociclib, you have good data showcasing that in a triple positive breast cancer, along with anti-HER2 therapy, along with letrozole, you can also add palbociclib, which will help in improving your OS and PFS. This is just, I'm just trying to keep the plate clean over here for us to know what to do. In HER2 positive, hormone negative, the standard as per ESMOS, we stick to the Cleopatra trial and go ahead with that itself. And second line, so if I may, who else is there? My Dr. Prahalad, Dr. Supreet, is Dr. Supreet around?
Yeah, sir. Hi.
Hi, Supreet. Friends from Chennai again now. Last week we both were in Chennai. So, what would you do? What in the second line treatment? What are your plans? Like, what is your normal practice in private practice? What do you do at Shankara? you might have some patients who can afford everything, some patients who can't afford. So what can you just run us through your clinical thought process, please? I'm
So,
sure you'll be very good at ratting out the guidelines, but we would love to hear what you actually do in the clinical scenario.
so is it the entire treatment course that you're asking, so to begin with
Second
first
line.
line?
We'll stick to second line treatment who have progressed. So you could
Okay,
have.
if somebody has already received Cleopatra in the first line, and and the patient is HR negative, then my approach would be TDXT. My discussion would be TDXT versus TDM1. And if the patient can afford, TDXT would obviously be the preferred choice. And if the patient has HR positive disease there, I would probably take a more nuanced approach, because I would see where the progression is and what all sites the progression has happened. That would kind of give us an inkling as to what could be the driver behind that particular progression, whether it is HR component or the HER2 component. For example, if it is a brain progression, there probably I would err towards offering TDXT, while if it is just a single bone met or a single lymph node here and there that has progressed, there probably I would tweak the hormone therapy and continue the same Cleopatra thing. Of course, after offering some form of local therapy.
Very interesting point that you brought out, Supreet. The point is about in a HER2 and a triple positive, which is the bigger of the drivers? Is it the HER2 or is it the
HER2.
hormone
It is
therapy?
the HER2. I agree that it is the HER2, but we should also not forget the fact that HR is also driving the disease, and there is always this crosstalk happening between the two. And if it is a limited disease progression, and if it is just a single skeletal lesion that has progressed, there probably I would still continue to use Cleopatra, but change the hormone therapy partner maybe.
I'm sure all of us would agree on the forum that if you have a triple positive patient versus a hormone negative and HER2 positive only patient, the triple positive patient does better, has a better survival when compared to the only that is hormone negative and HER2 positive patient. So don't we want to tweak that's when actually that's based on that the Patina trial came in with that philosophy, saying that
Correct.
let us hit the anti-HER2. Most for all these years, we've been only focusing on HER2 and let the poor hormone therapy be handled only with a flimsy letrozole or an anastrozole. So then they said, let's give some gusto to it as well. And then, so why I'm again saying is it's commonplace that all of us have been giving more weightage to the HER2, but like you rightly said, we have to give a lot of credence to that as well, because the hormone positive, HER2 positive patients technically do better than the plain HER2 positive patients. So hormone therapy is also of paramount importance in these patients. Okay, so Annie, what factors influence your choice of ADCs and the timing of introduction in clinical practice?
So here we are talking about a metastatic breast
Correct.
cancer. We would, in a triple positive, as Dr. Supreet rightly said, we will see which are the disease sites. It's a very aggressive disease. It's a indolent disease. So that is sites of disease. Is there any visceral crisis which is present? So, and is there brain mets, or there are other visceral like lung or liver mets which is present? Why? Because if it's just a brain mets, then I would err towards a tucatinib side. Otherwise, I will go in for a TDX. So that's where my introduction of ADCs will come in. If there is, apart from brain, there is other sites also which are involved, like lung, brain, liver, other sites. So that's where my ADC will supersede my TKIs which will come in, and I'll prefer a ADC there. But if it is just a brain, then probably tucatinib may come a little ahead. This is after I have finished my HER2, Trastu, and a taxane. And of course, if in a triple positive, because of the patina, now I have been adding on the CDK4/6 as well in the first line setting, that is in a triple positive.
Okay, patient can't afford TDX. At that point in time, what would be your thought process?
If the patient cannot afford TDX, then I'll have to see which are the sites of TDM1.
You have disease, lung, liver, bone, brain. All of them are like aptly involved. So you have some minimal amount of hypoxia. The enzymes are not elevated. patient has some amount of symptomatic brain mets, and you've given radiation aptly. So then afterwards, you're like, okay, you've done TRAS2 per2. What would you like to give next? And you know that patient can probably afford TDM1. Of course, they're able to afford. And then TDX is slightly out of budget. In that kind of scenario, what would you like to do?
Since if it is if they have progressed on per2 TRAS2 and they cannot afford TDX, then I will go for a TUCA based or a TDM, whichever they can afford.
There is data
Why,
for
why not?
data for
Why not? Excuse me. Why not lapatinib? Why we forgot
Okay.
lapatinib?
Very good.
Yes,
Very
that
good.
I will keep it for later. If they can afford tucatinib, I'll go for tucatinib capecitabine based therapy. If not, TDM1, because if we look at the PFS rates there, TDM1, the PFS is very less actually. In the Emilia trial, if you look at, the things are very less. So it will be what the patient could afford for probably 6 months financially, because sir said TDX they can't afford. That's why we are having this discussion about what could be the second line. Of course, lab cap would be coming in. This will be the 3 lab cap TRAS2 will be coming in as one of the option, but I would keep it a little down.
Because everybody, once it comes a TDX2, TDM1, we are forgetting lapatinib. We manage the HER2 brain metastasis with lapatinib for the long time with lapatinib, lab cap. We should
I agree very
take
much.
this point and.
That's where actually when with lab cap, then tucatinib took over, and they found that tucatinib gives you a better PFS and OS. So therefore, lab cap has now gone as to third line, fourth line. Like after you start off with brain mets, you do tucatinib, trastuzumab, capecitabine, and then subsequently you try TDX, and then after everything fails and the patient is there alive, then you do lab cap. Now that's unfortunately lab cap has gone down as the fourth or fifth line right now, Sampath. So
Because I tell you why it is gone down. We have a lab cap. We have used. We have taken a data of the 1.5 decades back. We never compared tucatinib versus lab cap. So there is the crux. So we I think all our medical oncologists manage the lab cap for a longer duration. I think we should
Agreed.
give some credit to the lab cap here.
Yes, many of us yet use lap cap because it's more easy, convenient. And Supreet was also mentioning something, the new combination he was mentioning. Would you like to finish that?
Yeah, there is data of HER2 climb 02 where there is TDM1 plus tucatinib combination.
Correct.
So if somebody has CNS progression and TDXT is something that they cannot afford, I would want to use the best of 2 approaches. For systemic control, I have TDM1, and for CNS control, I have probably tucatinib. So that would
very well, very well. So that data is also coming up right now. So that's also very exciting data. TDM1 plus, so a lot of permutation combinations trying. So now this one slide, which the company, this is company's on the slide. So if you have PIK3 mutation, so if I can just ask Prahalad, actually, do we actually check PIK3 in HER2 positive? This came as a learning for me as well when we were preparing for these slides. So I'm sure like most of us, until you can probably tell me if any of us are doing PIK3 mutation analysis in HER2 positive disease?
No, sir, I don't check the PIK3 routinely in my.
Any one of our panelists, please?
So in the case where we have used blocking the HER2, blocking the hormone receptors, where we are not getting a control out of this, then we can think of a PIVK mutation.
Sure, I'll have to be honest. I was not very aware that we would do this for HER2 positive breast cancer prior to this particular discussion. So when I started researching about it and studying about it, I realized that my question was, is PIK3 mutation equally present in HER2 positive when compared to hormone positive? In hormone positive, it's present in somewhere around 40%, ER/PR positive. In triple positive, it's seen in around 30%, and in only pure HER2 positive, it's seen around 20 to 22%. So this is the data that I got out. And then they say that if you're able to target this, you are going to get a better PFS and OS. So therefore, now this is a new learning. Many of our patients who are not responding, we should start looking at PIK3 as well. So that's some new learning for us today. Okay, there are a lot of other stuff. So now visceral brain mets, which I'm sure most of my colleagues have already spoken, my panelists have spoken. So I just, the HER2 climb, it's got a very good PFS hazard ratio of 0.54. And then hazard ratio of in intracranial progression and death is around 0.32. Median OS is around 21 months, and in the control arm was around 17 months. So brain mets, tucatinib, trastuzumab, capstable. Then this is a question that we were having in first line progression, TDX versus tucatinib. We can use the tucatinib triplet when active or progressive brain mets, as per the guidelines, as per ESMO as well. What he says is, if you have active brain mets, use tucatinib. If it is a quiescent or control brain mets, then you favor trastuzumab deruxtecan. But for our practical use, most of us, like my elite panel has spoken, tucatinib seems to be the flavor of the day, as and when you can use it. Then subsequently, you would position TDX. So, Annie, with the advent of ADCs in earlier settings, do you foresee a shift in the guidelines where ADCs move into the first line settings?
Yes,
We are
sir.
talking about DB9.
Yeah, DB09, it is quite interesting with the PFS having a benefit, but I would, the DB09 has shown excellent PFS, but I would still not put it as my first line because we don't have OS data. Probably once we have the OS data, I would consider it for a certain cohort of patients, probably where the burden of disease is high. Why? Because I don't have anything good in the second line, which can be used if the patient progresses on DB09. So as of now, it is interesting, but I would still wait for the OS data.
Very well. This is the common thing. Like we can see this particular slide here, DB09. The PFS data itself is like OS data is not mature at all, and PFS is going beyond the computer screen. It's that kind of a fantastic response that is there. But again, the concern that all of us have is that what next? After this, what happens? But then what we probably need to understand is something similar to what happened to osimertinib and what happened to lorlatinib. You need to use the best guy upfront to ensure that you have the best quality of life and patient lives for that long, and subsequently you will have a detopotamab deruxtecan, or you will have a sacituzumab govitecan coming in, or one of the other drugs which might come in. So now the again trastuzumab deruxtecan plus pertuzumab, for all you know, then you'll have some combinations of trastuzumab deruxtecan plus tucatinib as well. So these combinations are coming in as well. Very, very exciting data in the near future. So again, now the standard of care, just for us to understand, we start with the first line Cleopatra. Then we look at whether it is a progressive CNS disease and it's tucatinib based. If it's stable disease, it's deruxtecan based. Then subsequently, like when Annie mentioned, what happens thereafter? If we've used TDX upfront, then we go in for TDM1 or tucatinib. We have this whole array menu card. The best drug to use right now, we are using it as DB03. If we start using it as DB09, subsequently you'll be using the rest of the drugs, albeit the response may be, the PFS benefit is going to be lesser, but the first PFS that you're going to get is going to be fantastic. So therefore, like I strongly believe that in the near future, if not very, very near future, DB09 is going to actually be a mainstay in our therapies. Are there any challenges with introducing ADCs earlier? Like now, Annie mentioned that she would love to do it, but right now she's waiting for the OS benefit. So my dear friend, is the Lieutenant Colonel there, Dr. Kaushik? He ain't there. So then afterwards, then Vijay is there. Is Vijay around today? I couldn't see his name as well.
Yeah. Hi, Rajeev. Sorry,
Hi. Sorry, I
late.
could not see your thing on that. So this is
No.
now we are now coming to the mutation man, Vijayakumar. So apart from winning the Tamil Nadu elections, the name Vijay also resonates with the guy with all the mutations in Bangalore. So please share your thoughts about this. When would you want to? You can do DB3 or you can do DB9. So what would you like to do in the first line metastatic setting? Would you like to do? Someone says, let's do TDX. Your thought process, please. What challenges would you face?
So in the first line, I don't see. I clearly agree with what Dr. Annie was saying. There is no OS data to kind of consider it in the first line. But the way I look at it is, eventually, even though the OS data is not going to be there, or it would take some time for it to mature, I think TDXT with pertuzumab would probably be the way forward, because nearly 1 in 3 will not be the fittest to develop to kind of go in for the second line. and also with a high risk of brain metastasis in these patients, you need a drug which is more potent in the brain. For us, I mean, we've seen in practice in majority of the times that you always start them on, say, a doublet with, say, trastuzumab, pertuzumab maintenance, and you see close to 20 to 30% of patients coming back with brain mets as this primary site of progression. So if you're really trying to look at that particular area, I would probably push for a TDXT kind of a combination upfront because it has very good intracranial activity and it's shown in the second line. So I think with time, we would probably start incorporating this in the first line because you have a bunch of ADCs in the second line. Although there is a lot of crosstalk or cross resistance when you use one ADC in the first line, there is data which says that your level of expression do drop. So there is studies from EV in urothelial bladder cancer where they looked at when you started using EV in the first line, the TROP2 expression do drop. So SG, that was one of the reasons why the SG, although had an approval in the second line, was later withdrawn when they progress on EV. So that's always, it's an evolving thought. But having said that, there is also studies where you're combining EV with SG in bladder in the first line metastatic setting. So it's an evolution. We don't know how it's going to work, but then I would think the future is going to be that way. You would start using more ADCs on ADCs till kind of choosing what is your dose limiting toxicity at some point in certain patients.
Very well, very well. Dr. Srinivas, are you there? Dr. Srinivas? He ain't there. So, okay. So, Dr. Sampath, so would you like to, if you start it upfront, do you have any fear of starting TDXD upfront? Let's consider patient says, doctor, I have all the money in the world. Give me the best treatment. I heard DB9 is good.
Hello?
It's got PFS.
Please repeat.
The patient is a chat
Rajeev, please
GPT.
repeat.
Patient is a chat GPT well-read patient and says DB9 has the best response rate, super PFS. It's gone beyond the computer screen. So please give me TDX upfront. What will be your thoughts?
Yeah.
What
Apparently,
challenges?
I'll use. I won't give an option of Cleopatra. I'll directly give a DB09. What else you want? 60 months PFS is there. What else you want? I don't know. Why people
So
are still
challenges, what?
depending on.
I'm asking you, what challenges will you think of?
Means toxicity wise.
Correct. So that's a challenge. That's basically
Toxicity wise, financial toxicity. Financial toxicity will be there, and interstitial disease, that is 10%, but I have never come across those patients. Maybe on the paper, but we don't see. But 60 months, more than 60 months PFS data, you don't get anywhere else in the drug. That's the reason I will use apparently TDX2.
Have you ever used upfront? I'll be very interested, excited to look.
Yeah,
Very,
I've
very
used,
nice.
and yes, only thing is we have a payload more cytotoxicity, and mainly is neurotoxicity we have to manage, because that manantinenset, that is a very neurotoxic drug, which is they combined with Deruxtecan is a very neurotoxic. Then I am giving a gap of 1 month. I'm pushing to the 1.5 months, like that. Yes, I am using this in a upfront way, in a upfront basis.
You've seen neurotoxicity with it. That's nice.
Yeah.
Most of us
Deruxtecan
have
is there,
seen a large number of. Huh?
Sir, I just have a small point to make.
Please.
If I may. So,
please.
While I do agree with all of you to the fact that this is giving us the best PFS that we have ever seen, and it is something that is phenomenal, we should also understand the long-term impact of this particular treatment, because all we are talking about in metastatic malignancies is about quality of life, and here we are offering a drug with a potent cytotoxic agent tagged to it, which causes nausea, vomiting, and imagine this being given for about 5 years or till disease progresses. That is something that we should counsel the patient, and if the patient is really motivated to go through all that, that is probably those are the kind of patients where I would also be motivated to. But apart from that, if you want to choose medically, they're HR negative, HER2 positive, somebody with high disease burden, high metastasis, and now there is also a concept of switch maintenance that we are getting. So you give TDXT initially to somebody who has got high disease burden, and then switch to Trastuzumab or plus hormone therapy maintenance or whatever. So I think that would be the way forward, doing something, doing a mixed approach.
That
Very
I
nice.
also
So
agree.
actually,
I agree with. That is a one more method. One method you can switch over to the trastuzumab, and one more method is that you take a when you are giving a initial induction, you give a proper dosage. Once you get a control, you can space it and you can reduce the dosage. You can get a benefit out of it. We all know that it is we cannot able to give a for a longer time, but anyway, in there you can reduce the dose or do the spacing, or you can do the both the things. Once the disease under control, I think we can do this switch thing.
very nice. So just for our consumption, I have a patient who had cardiac toxicity, and after doing a lot of study, tucatinib seems to be the next best choice. And after the tucatinib, the next best choice is TDX. In terms of the least amount, all of them can cause cardiac toxicity again, but the least toxic is in order of severity is tucatinib, and then TDX. So well. I'm going to spare you all this. We've already overshot our time, so I'm not going to spend too much time on this. Okay, next. Okay. So now practical metastatic sequencing as requested by the chairperson. First line, trastuzumab, pertuzumab, taxane for most fit patients. Second line, TDX, if no contraindication or no urgent CNS priority override. Third line is tucatinib, trastuzumab, or capstebin, or whenever there is a CNS priority, use this combination. Subsequent therapy, if TDM1 is not used, poor old Calzilla, he also comes into the picture and says, hey, I'm also there, I'm going to be used along with neratinib if we do get the drug in our country. So 3 take-home clinical scenarios: de novo metastatic, no CNS, Cleopatra. Post THP active brain metastasis, tucatinib. Residual disease after the TDM1. So now the next set of it, we are now talking about, we spoke about in proper HER2 positive. We are now talking about hormone positive, HER2 negative. So Annie or Prahalad, I'm not engaged Prahalad much. Prahalad, your thought process, please. Hormone positive, HER2 negative, patient is progressed on therapy.
I think we should see what rapid progression, endocrine resistance, what was the duration and sites of disease
Very
before
nice.
we go.
Very nice.
I think that endocrine resistant depends, and then we get a repeat biopsy and test for HER2 low as per the new guidelines, and then discuss with the pathology and proceed with TDXT based on sites
Do we
of
actually
disease and the rapidity of progression.
would you like to say that whether the original biopsy specimen itself, you want to get it checked for whether it is HER2 low, because pathologist might recommend it as negative, but you want to get that, or is it necessary for us to get a repeat biopsy done at that point in time whenever there's a
repeat biopsy
progression?
as per the new guidelines? We check and then check for the staining, low as well as the ultra low, and then decide on further.
Fine. So basically, hormone positive, HER2 negative, no chemotherapy unless there is visceral crisis. That's what our understanding is. But if the patient is like he rightly said, so all right. Vijay, so how do you decide clinically if the patient is endocrine resistant or not a candidate for endocrine therapy? Basically saying that, okay, you've given your fulvestrant or you've given your letrozole, Abima, Ribo, Palbo, and then afterwards patient is yet has progressed on that. So you're like, I have to change therapies. So how do you clinically decide? What clinical features do you look for?
So clinical features, one is looking at the site of metastasis and see whether patient has visceral disease or visceral crisis. So that's again important for us to define what it is. And timeline, clearly that's something in the adjuvant under 2 years, on adjuvant under 2 years, or in the metastatic setting within 6 months. If there's progression, then you would put it as endocrine resistant. So that's where we start exploring more options. One option is to look if patient is a candidate for BRCA or say HR positive. I mean, look at PARP inhibitors as an option. If not, then you would jump into TDXT. The data is really strong. You would probably encourage TDXT at that point.
Very well. So actually, when I was just going through NCCN, ESMO says you can do either. NCCN says category 1 indication, systemic chemotherapy. Category 2A is TDX. So now this is in 1+, 2+-ish negative patients as well. He says do systemic chemotherapy. Probably this, Annie, what do you say about this? DB3, DB6, DB9 or chemotherapy? Hormone positive, HER2 negative.
Yeah. So if
Your
they're
thought process on this?
Yeah. So again, I would look at the place where they have progressed. If systemic chemotherapy, if TDX they cannot afford. Second is if they have an aggressive disease and I want a rapid disease control, then probably I'll put systemic chemotherapy a little ahead. But if I want a rapid response, then I would play systemic chemotherapy. Otherwise, if it is low HER2, then I would go for TDX, because I
Fine.
have been using it. I have been using it TDX in after the patients have progressed on CDK4/6 plus letrozole, and if they have had low HER2, TDX would be my go-to regimen in the second line.
Fine. At the same time, let us all not forget our humble pick 3 as well, like we've just discussed prior. And it will be a good idea to look for a BRCA in the situation as well. To ensure that we complete our basics in this. So we take care of that. Then afterwards, then we say the holy grail, we go into TDX thereafter. So again, over here, this is like the ESMO 2025 current pathway. Patients hormone positive, HER2 negative, not candidate for hormone therapy or targeted therapy, no prior chemotherapy. If it's HER2 low or ultra low, Deruxtecan. And if it is else, you can do a taxane bev or capsitin bev therapy. And then if the patient has received prior chemotherapy for metastatic breast cancer, HER2 low Trastuzumab Deruxtecan. Else, and if it is ultra low or if it is not ultra low or if it's negative, then Satheesh Govitecan or Datopotamab Deruxtecan, both of which are unavailable. But Satheesh we've used for a couple of patients and found to have okay responses. So that's with that. So then afterwards, Dr. Sampath, what would be a treatment choice for a HER2 low post-progression on first-line therapy with chemo or Trastuzumab Deruxtecan?
Rajeev, you are asking me?
Yes, Sampath.
HER2 low.
HER2 low. So that is like 1 plus.
1 plus
HER2
or
1 plus.
0? 1
1
plus.
plus, 1 plus. 0
1
could
plus.
be 0 or that will be null or ultra low, we will call that. Here, HER2 low is 1 plus.
1
Would you
plus
use
I
chemo
used, I
or
didn't get a good
Deruxtecan?
benefit. Mostly I'll go with the chemotherapy in this patient.
Okay. And my other colleagues, Vijay? Supreet?
Your treatment choice for HER2 low. So post-progression on first-line therapy, I would still kind of use all the other ones before going TDXD. Like I said, I mean, going by all the other parameters, visceral crisis,
Right. Correct.
all of these, look for pick 3, look for all the ones which could probably act. And then if all of them are kind of exhausted, then I would kind of go with TDXD. But then again, the data for DB06 is also very promising. Hazard ratios of 0.33 in the second line, although that's for HER2 positive. But it's something which is definitely worth considering.
So now this is for this is just the OS in the secondary. This is just I'm just showcasing this. We have a hazard ratio of 0.83 in the HER2 low segment. This is for us to understand that even if when treatment of physician choice, that is chemotherapy versus TDX, in this scenario, hormone positive, HER2 low, after progression of initial therapy, you yet derive benefit with this. So 20% of patients in the physician's choice group received TDX thereafter, after post chemotherapy discontinuation. So this is just for us to understand that the curves are not very wide apart, but there is definitely some amount of numerical benefit. Although the p-value is not very statistically significant, we need to understand that HER2 low, this is a therapy that we can offer our patients. All of us, like Sampath and Vijay and Annie told, that we are yet our chemotherapy guys. We would try to use chemotherapy to reduce the burden of disease, but here we are. This is in HER2 low population. Okay, now some a part of it which probably both Annie and Vijay spoke about. Do you have a therapy preference based on the time to progression? So this PFS by time to progression on first line endocrine and CDK4/6 inhibitor and endocrine resistance. Whom can I ask? Prahlad? Are you there, Prahlad? Or are you there, Supreet?
Yeah, sir.
Please, your thought process on this, please. So basically, like time to progression, which the previous panelist alluded. Your thought process.
So the time to progression is nothing but indirectly it is indicating how hormone sensitive still the disease is. So if the time to progression is longer, or the scale of progression is not much. So that is where I would keep tweaking and playing around various hormone therapy options that we have, including but not limited to drugs like everolimus or capecitabine metronomic, fulvestrant, or all those newer drugs that we are getting. But obviously, as the number of hormone therapy lines that we keep using, the disease keeps getting more and more resistant, and the PFS keeps getting shorter and shorter. And there will be a time point where we do understand how the disease is, that the disease has shifted its gears, and that is when probably I would do TDXT. And there, I agree with the fact that TB06 has performed much better than chemotherapy of physician choice. So if it is HER2 low, then definitely it is TDXT over chemotherapy, and later on probably chemotherapy.
Okay, so because this becomes an important question that all of us still rate whenever we have a hormone positive disease, we do our letrozole plus CDK4, then afterwards fulvestrant plus CDK4, look for a PIK3C mutation, add oral metronomic chemotherapies. So this is how we've been going, and we've been buying good amount of time actually. So then comes the question that when do I actually know I have a TDX also over here? It might be 1+, it will be ultra low. Do I choose a TDX, or should I stick on with tweaking like with so many other drugs? Because we all have our patients who are doing well on hormone therapy for 7-8 years. They've undergone almost 4-5 regime changes. So Annie, your views on this, please.
Yes, sir, you're right. If that again, the timeline to progression helps us decide how the biology of the disease is. So probably now, when we do an NGS and look for this PIK3CA and other parameters, that would give us an idea as to whether they will progress. But if the patient has gone on for like 3-4 years, when we have just switched the hormone therapies, and when they progress, the mutation burdens actually increase. So in that scenario, probably if we identify mutations which may render resistance, we should use the therapy which we will act. And I feel HER2 low, sir, we should be actively looking, because we should the quality of life also matters, because we know that in the 4th and 5th line, if when the patient progresses, their performance status actually worsens. So I feel that HER2 low, that space, now that we are aware about its testing, if it has been deemed negative, we should also look it in the 3rd and 4th line, if not in the 2nd line. So if the patient has been going on having an indolent disease, but at least we should actively look for this HER2 low space now that we have TDX.
Very well. So the important thing is that we were probably not looking at anti-HER2 therapy till a year back, or even contemplating. It was not there inside our mind space at all. Now it has entered our mind space. It's just a matter of time when we will start actively hunting for that 1+ or that ultra low, and say that he will or she will benefit. Some amount of benefit would be there. I'll probably play with this anti-HER2 therapy for some time, and then switch back to hormone therapy after, then do oral metronomic, and so on, and then keep prolonging the life. So, Dr. Sampath, is Destiny Breast 6 practice changing? Should all patients receive TDX in the earlier setting? I've just put the. Are you there, Dr. Sampath? So, probably
Yes.
Sampath.
What is the question? Sorry.
Should we do, like you can see this flow chart in front of you. You can see here the ADC Destiny Breast 6 upon upfront endocrine resistance after doing a hormone therapy plus CDK4 inhibitor. Initially itself, if it's 1+ or low, ultra low, should you go ahead with DB6? Is your therapy going to change accordingly like this?
Means you mean to say TDX will use or not?
Correct.
Hello?
Are you going to use it as a first? Yes. Are you going to use it as a first line after endocrine resistance, progression after endocrine resistance? Do you think it's going to be your practice? Or are you the standard old school strong guy who's going to say that, you know what, I'm going to play with the other drugs more and then do this?
I think I'll play with other drugs and then I'll come back to this.
Okay, let's have a show of hands. Vijay, your thought process on this question. So are you going to, is DB6 practice changing? Should all patients receive?
So yes, if it is endocrine resistance, yes, clearly the DB06 data is very strong. If it's endocrine resistance, then I would, especially the one in the where there is resistance within 6 months on like the exact inclusion criteria. I am happy to use it. If it is a progression within 6 months in the metastatic or in the 2 years in the adjuvant setting, I would definitely consider because the data is the strongest.
Hazard ratio of 0.57. So that's the story for that.
Yes.
Okay, and then afterwards, Prahlad, your thought process, please.
Yes, sir, definitely. Yes, probably we should consider using Destiny 6 post progression on ET plus CDK4/6. I think we should wait for the long-term results. Definitely, I think with good PFS, 13 months, definitely we can incorporate this.
That's nice, and since we would all love to do that, but I'm very happy that all my my colleagues have very rich patients who are able to use TDX upfront on this. But that will be something that it will be very interesting to see whether how the overall survival data pans out. So, well, this is the question for the pathologist, but I think we don't have a pathologist on board, and Dr. Sai and Mansi spoke about in detail about the histopathology part of it. So I will just spare us all on this. So I think it's been a very interesting discussion with all of us. The lot of different thought processes, it's evolving thought processes. What was the rule yesterday is no more the rule today, and what's the rule today will not be in practice tomorrow. So anyway, thank you all for such a fantastic discussion. I'm very happy, and thank you, AstraZeneca, for this opportunity.
Thank you, sir.
Thank you.
Thank you.
Thank you so much, sir. It was a wonderful discussion. On behalf of AstraZeneca, I would like to thank our program director, moderators, speakers, and panelists for joining in for today's webinar. Thank you so much, sir.
Thank you, sir.
So,
Thank you.
with your permission, I may end the meeting, sir.
Thank you. Thank you.
Thank you.